Hello, everyone, and welcome to the Axis webinar, Wired Differently, Navigating Anxiety and ADHD in Adolescents and Young Adults with X and Y Chromosome Variations. We're very happy that you've all made it tonight, and I'd like to introduce the speakers. Dr. Kate Dreyer obtained her master's degree in clinical psychology in 2008 from the University of Hartford, where she also graduated in 2012 with her Doctor of Psychology. For the past 7 years, Dr. Dreyer has focused on pediatric neurodevelopment assessment. In 2024, she joined the section of developmental pediatrics at the University of Colorado School of Medicine. She practices at Children's Hospital Colorado, where she completes assessments and conducts therapy with the neurodiverse pediatric population, with an investment in providing compassionate, strength-based, and whole person care. Also with us tonight is Dr. Joanna Dreyer, is a board member certified pediatric pharmacy specialist and clinical pharmacist at the Developmental and Behavioral Pediatrics Clinic at Children's Hospital Colorado. She specializes in medication therapy for behavior and emotional health in those with autism and other neurodevelopmental disabilities. Her current clinical interests include safe and judicious use of atypical antipsychotics and medication management for those with attention deficit hyperactivity disorder. Her current research focuses include medications for behavior and mental health in those with 48XXYY syndrome. Thank you, ladies, for joining us, and we'll pass it over to you.
Hey, wonderful. Thanks, John, and thank you guys for having us and sharing your Monday evening with us. This is a huge topic, anxiety and ADHD. So certain areas we're going to move through more quickly, and we'll try to stick and spend some time in talking about some real life day-to-day practical strategies and consideration for adolescents and young adults with XY chromosome variations and ADHD and anxiety. Also, please bear with us. We are sharing the slide sharing and slide navigation duties. So there might be some brief blurps and delays, but we'll get all the information out there. So our goals today are really to understand the prevalence of ADHD and anxiety within the context of XY chromosome variations. And as I mentioned, trying to spend some time and thinking about real life presentations and daily considerations while reviewing evidence-based behavioral and medication treatment interventions. To sum this up, we don't really have any financial disclosures or conflicts of interest to mention. One thing I will highlight from this slide is that we are not able to make individualized or specific treatment or medication recommendations. And Joanna will also be discussing off-label medication use, which we'll chat about through the latter half of this presentation. So we've got a really simple answer to this question that I think all of you guys are familiar with. Are anxiety and ADHD more common in teens and young adults with XY chromosome variations? Yeah, they absolutely are. The literature varies depending on what specific type of chromosome variation we're looking at. But prevalence rates range from up to 36 up to upwards of 50% of teens and young adults with XY chromosome variations will have co-occurring ADHD and or anxiety. Okay, so we need to be paying attention to these things. We need to be talking about these things. Thinking big picture and kind of starting at the top here, XY chromosome variations are associated with differences in brain function. And you can see this slide outlines some of those differences in brain function. And what we're going to be focusing on today is that anxiety piece and the combination of attention span, distractibility, hyperactivity, and impulsivity, and how that can come together within the constellation of an ADHD diagnosis. Okay. So I'm moving through these initial slides fairly quickly because I think that these are concepts that that many of us are familiar with. So when we're talking about ADHD, there's three main types. An individual can have a predominantly inattentive presentation, a predominantly hyperactive impulsive presentation, or combined type. And I think that's what folks most commonly think of when we think about ADHD. So in order to meet, diagnostic clinical criteria for diagnosis of ADHD, there need to be 6 or more symptoms of inattention and distractibility, or hyperactivity, impulsivity. 6 or more in either of those categories or both, which is where we see that combined type of presentation. We're looking and checking if these symptoms and traits occur across environments, thinking about home, school, community, and whether they're causing day-to-day challenges or functional impairment or difficulties. Okay, so when we're talking about ADHD, we're going to root us in this. ADHD is more than inattention. I'm not sure if folks have seen the iceberg metaphor of ADHD, and we've got the tip of the iceberg there, where we have inattentive, hyperactive, impulsive traits. And then below the surface of the water, we have all of these other things. So I think in social media, you might hear a lot about like analysis paralysis or time blindness, difficulties with task initiation. So there's all of these underlying challenges that I think become particularly salient and important to think about for our adolescent young adult population. And we'll dive into some of these things throughout the presentation. Also, equally, or perhaps more important, is highlighting some of these strengths. If you know and love somebody with ADHD, I'm sure you can identify with some of these things. We tend to see a lot of creativity and resourcefulness, an ability to sort of think on your feet and dive into a problem and approach it, or dive into a situation. There's a lot of resilience in that, a lot of innovation. Certainly, we might see more, a really nice sense of imagination and sense of humor, and things like that, that I think are really, really important to pull on and highlight, particularly as we're entering those teenage and young adult years when we're thinking about, hey, what environment am I or is my child going to be most successful in? Okay. So ADHD is a complicated diagnosis in itself. It's certainly a term that gets thrown out a lot, like, oh, I'm so ADHD, or my ADHD is showing, or some phrases that I've heard more recently. And ADHD is complex when we're thinking about teens and young adults with XY chromosome variations. So when we think about, for example, you can see all these dynamics here that make it complex. And I want to pull out and highlight some considerations that I think are particularly important for teens and young adults. So one, that learning piece, ADHD is associated by itself, associated with increased risk for learning disorders and specific learning disability. XY chromosome variations by itself is associated with increased risk and increased vulnerability for learning challenges. Okay. So if we combine those things, essentially what we have is a compounded risk for learning challenges. And as we're transitioning into, I think the transition to middle schools can be particularly challenging, and then the transition to high school can be incredibly challenging, or any sort of college or post-secondary education setting. Though the executive functioning demands jump so significantly in those environments and in those settings. And what I've found clinically time and time again is it's really challenging to get the right academic supports. And sometimes more than ever, caregiver and self-advocacy becomes really, really important. There's such a shift to, hey, you've this is your homework. Go do it. right? And we've got to break down those specific skills and components of completing that task. And I'll talk a little bit more about some of those strategies here in a bit. Social emotionally, we often hear our teens and caregivers of teens come in and say, they seem so much more immature than their similarly aged peers. And so that ADHD component, that under the iceberg trait of some mood fluctuations or mood swings or irritability can become all the more challenging in the adolescent years. That difficulty connecting with similarly aged peers, and then contributing to a sense of disconnection of, I want these social connections and I'm having trouble navigating them and figuring it out. And that stinks. That's a really hard situation and emotion to navigate and to help your loved ones navigate. And tied to that are our language processing differences. So in individuals with XY chromosome variation, receptive, this is broad strokes, it's not true for everyone, but receptive language skills tend to be stronger than expressive language skills. We're often thinking about an individual's ability to express themselves and say, I'm feeling this type of way, I need this, or I want this. But before we've even gotten to the point of verbalizing or expressing needs, language provides this internal process of helping us organize our feelings, right? And identifying in our heads that, hey, this is what I'm thinking, this is what I'm feeling. So it mediates our social emotional needs, again, before we've even gotten to the place of verbally expressing what those social emotional concepts or needs are. And language processing differences tend to be really prominent and something to pay attention to. We also start to think about the environments in which teens and young adults are more likely to find themselves in. So a lot of language heavy, language rich environments, and there can be increased difficulty processing lots of talking, particularly in environments where there's a lot of background noise. And that's where some sensory differences come into play as well. So all this to say is there are unique considerations that we need to think about when we're thinking about the intersection of ADHD and XY chromosome variations. And on our next slide here, what you'll see is an additional layer, special considerations and unique considerations for the adolescent and young adult population. So one thing we commonly hear about is symptoms shift. Okay, so we might hear folks say, yeah, I don't think I have ADHD anymore, right? My ADHD is gone. Congratulations, right? Like I became an adolescent and there we go. It's gone. Really what is more likely than not happening, and that we tend to see more happening, is that symptoms are shifting. Okay, so those hyperactive impulsive symptoms, if they were something you or a loved one had when they were younger, those tend to kind of simmer out a little bit. And or individuals find the environment that's a good fit for them. Okay. So those hyperactive impulsive symptoms don't really feel problematic anymore, but they're still kind of sneakily there underneath things. We also need to think about, for any adolescent and young adult population, there's different consequences. And I would argue that there's somewhat higher stakes, right? So impulsively, like kicking a ball on top of your neighbor's roof when you're in second grade, not a huge deal. I guess unless your neighbor is quite cranky or disgruntled by that sort of thing. But if you make a really impulsive decision when you're 18 and buy something wildly expensive that you can't afford, that's a very different consequence, right? In a very different way that impulsivity is showing up. We also have these age-related, chronological age-related expectations related to independence and daily living skills and demands. And what we see in individuals with XY chromosome variations is that there's a different kind of developmental timeline and trajectory. So when we quote unquote think a skill should be coming online or established compared to similarly aged peers, it might not be. And that can lead to a misalignment particularly between what other folks who might not be familiar with these needs expect. A misalignment between size, really tall, and kind of thinking, yeah, they should be able to do this, and developmentally, where the adolescent or young adult is. And a lot of these demands and expectations for independence are unwritten. Okay, we're just expecting folks to kind of watch and learn and pick up these skills. And what we tend to need more is some direct teaching and guidance. And an example I give, if you've heard me speak before, perhaps at this year's Access Conference, is like, okay, you're in high school now, right? You need to start making your own lunch. Okay, so if you want to feel really overwhelmed by making your own lunch, listen to my next minute of talk. If you don't, cover your ears. So make your own lunch. What are all the skills involved in this? So first of all, we have to think of like, what do I even like for lunch? How much do I eat at lunch? Do I have the groceries to make that lunch? And if I don't, how do I go get the groceries? Is it something that needs to be hot or cold? Do I have access to a microwave or a fridge? Do I need an ice pack to put in my lunchbox? Okay. When do I make my lunch? The night before? The morning of? How much time does it take to make a lunch? And I don't really want to do this. So now I've got that task initiation piece of just like, I'm just going to think about it for hours before I can mobilize myself to get going. Okay. And then you got to bring your lunch back home and empty your lunchbox if you have containers and all of that stuff, and do it all again the very next day. Okay. It is a multi-layered, complex task, and it sounds so simple. Go make your lunch. Okay. But there's really all of these executive functioning skills involved and embedded within this task. So when we have these things kind of come together, it can certainly contribute to some frustration for the adolescent or young adult, some frustration for caregivers and family members as you're like, just make your lunch. Okay. And again, there can be that mismatch between what we're expecting based on chronological age and what might be more appropriate to expect developmentally. And then what's the bridge that we need to get there. Okay. So on our next slide, we're going to talk and shift about anxiety. So that little portion might have brought up some anxiety of like, oh my gosh, I got to make my kids' lunch tomorrow. I got to make my lunch tomorrow. And really, there are all these embedded skills within that task. So I'm going to use that as my segue into anxiety. We've all experienced anxiety, okay? If you are a breathing person, you have been anxious, certainly. This slide breaks down the main components of anxiety. Physiologically, we feel the somatic experiences of anxiety in our body. Behaviorally, we might see withdrawal, reassurance-seeking behavior in our kids, teens, and young adults. And then the cognitive portion of anxiety, which becomes more complex and I think starts to come online more as we enter into adolescence. So these cognitive distortions, negative self-talk, a lot of perseveration and rumination on different anxiety-producing situations. We might start to see these what feel ultimately like unbalanced thinking patterns of, I got made fun of in 4th grade. And so it must mean if people are whispering, they're always talking about me. If I get up from my seat in 10th grade English class, everyone is going to be looking at me and thinking, oh, gosh, he needs help again. Oh, okay. So we tend to see a lot of more of those cognitive manifestations of anxiety as we enter into adolescence. The next slide, we'll talk about different types of anxiety disorders. And again, not going to spend a huge ton of time here, but when we're thinking about generalized anxiety, we're really thinking about persistent anxiety across settings and situations. Social anxiety disorder is fairly self-explanatory. Specific phobia about very, certain situations or things. And these are all some of the more common anxiety disorders. And I'm sure many of you and your child or loved ones medical chart perhaps have seen another specified anxiety disorder. And I think sometimes this particular anxiety diagnosis is more common in individuals with XY chromosome variations because there's components of lots of different types of anxiety. And it's hard to neatly put it into one diagnostic category, but we want to make sure that we're accounting for it from a clinical perspective. Okay. I just like this quote. It's a better meme than I was able to design here, but this thought process of like, what could go wrong? And anxiety being like, I'm so glad you asked. Don't worry, I got you. I will lead you through 22 various scenarios of how things could go wrong and be wildly anxiety producing. Similar slide here, anxiety is complex in XY chromosome variations. And I'm going to highlight a couple of different things here. Medically, we might see some sleep and eating changes and physical complaints, right? So this idea of I'm just feeling really worried and how I'm going to express that is my stomach hurts. The other side of this medical component here is that there's an increased risk of medical complications and co-occurring medical diagnoses and medical treatment needs that can absolutely build and contribute to a sense of anxiety. So if a kiddo has, epilepsy, for example, that is kind of going through a period where it's not as controlled as it typically is, we certainly see that contribute to anxiety. So it's really, really important to factor that in as we're thinking about anxiety and treating anxiety for kids with medical complications and teens. We've also got this mood component. So I touched on this before when it came to ADHD, and in anxiety, we see similar things of irritability, mood swings, and we might see meltdowns that feel inappropriate based on an individual's chronological age, but perhaps is aligned with where they are developmentally. And related to that, some of those executive functioning needs. So I feel like executive functioning is a big term that gets talked a lot about. I explain it as this front part of our brain that's in charge of higher order cognitive skills that very broadly are in charge of regulation abilities. So how we're regulating attention, emotions, behaviors. Regulation is involved in how we work toward present goals, what needs to happen right now, and also future goals. What do I need to accomplish in 2 months? Anxiety can come along with difficulty focusing as well, and some increased rigidity of I'm feeling nervous, I'm feeling worried, I need my environment to be predictable and structured. So we can certainly see a bump in rigid behaviors along with time periods of increased anxiety. Okay. And then I think next, we've got this social emotional domain here. And what I want to highlight here just mirrors a point I made a couple of minutes ago about some of the manifestations of anxiety might be aligned with an individual's developmental kind of age and where they're functioning developmentally versus saying, oh my gosh, I'm really worried because I got this big assignment. What we might see is clingy behavior that perhaps we felt like, hey, you did this when you were 5. Why are we back here? Lots of questioning. When are we leaving? How are we getting there? Who's going to be there? Is it loud? Do you have my headphones? So a little bit of that perseveration. Might see the avoidance. I don't want to go. My stomach hurts. I'm not going. And in our adolescent population, we might see an increase in screen time. I haven't met a kid, adolescent, or young adult that is not wanting to be on their screen or enjoying that. But we might see an increase in that, and that could be an indicator of some avoidance and withdrawal behaviors. So on our next slide, we are, if I could have my magic wand and say, how are we going to identify this? I would say best practice, right? We can do a multidisciplinary neuropsych evaluation. So it's very likely that if you are a parent or a caregiver and here for your now adolescent young adult child, or if you are an adolescent young adult you've had a form of neuropsych testing in the past. What I think happens, and I'm saying this as a provider that works with the full range of the pediatric population, is kids get older and we forget about this resource and about this tool. I know it's not always possible due to wait lists and shortages of providers and insurance barriers. And also, if this is something that you can have access to, I would think about it. What I find happens is, right, we know our kids, we're like, yeah, they were a little bit anxious, but we haven't necessarily done the digging to provide a diagnosis, to really unpack why, to really unpack how that anxiety or ADHD is showing up on a day-to-day basis for that individual. And this type of testing can really tease out a lot of that. And ultimately, the goal of if there's not a diagnosis, that can be important for communication and keeping it on the treatment radar. And based on that, more importantly, what do we do, right? What's going to be most helpful? So if this isn't accessible, certainly a good clinical interview with a doctor, a great therapist is going to get you that, get you some of that information as well. But I think that sometimes these things aren't caught or aren't diagnosed as they're starting to show up for our adolescent population. Tips and tricks. So these are some daily things that I've touched upon. Directly teach skills. This is huge. Break down these tasks into these minute details. Think of my lunch example. And all of those component abilities are in there. Use visuals when we're thinking about that language processing difference. So use visual schedules and reminders in a way that's going to make sense for your teen. I know some teens who love a great checklist. I do too. And some teens are like, don't you show me a checklist. So trial and error, right? We've got to figure out what's making sense and what works. Use technology, right? So this is where that comes in handy. Use reminders, use alerts, use all these things we have access to. Find the right environment. This is true for all of us. We have to find the environments that we're passionate about, that we like, where we're successful. But I think can be particularly important when we're thinking about things like anxiety and ADHD within the context of XY chromosome variations. So find the environment where you're thriving and where it builds on your strengths, and weaknesses and areas of need aren't as liabilities as much. And then check in and connect, right? Your kids are maybe not young anymore, but they still need that connection to come, probably in different ways, but it's just as important. And then we'll talk about some formal intervention. So a lot of these things you or your loved ones perhaps had when you were younger, right? Speech, OT, things like that. They remain relevant and applicable for our adolescent and young adult population. OT and even speech can be a great resource to help with some of these executive functioning skills that we've talked about. Certainly, like I mentioned, advocating for those school accommodations. And then we've got some evidence-based interventions. I'm sure CBT, cognitive behavioral therapy, is something that's come across your desk multiple times because providers like to talk about it a lot. It's got a lot of evidence. And in our next slide, I'm going to give a nod to some exposure-based principles. So these are some key cognitive behavioral principles and adaptations that are important to implement in our adolescent and young adult population. So plain language. This gets missed. We forget about this. We've talked about directly teaching skills. A couple of things I really want to highlight here. One is we still need some caregiver involvement, but we've got to obtain that and get that and consent for that in a different way when we're thinking about our teens. We want them to feel good about that and to have that happen in a way that's making sense for them and in a way that, to the extent that's developmentally appropriate, keeps them in the driver's seat. Okay. And here's my nod to exposure that I think tends to get missed. We need to do the hard things a little bit at a time. Okay. So if your kiddo really wants to master transportation, the transportation system in their town, because that allows them independence to go to different activities, but anxiety and or ADHD symptoms are getting in the way. We need to support them in a little at a time, doing that and working toward that. And that's going to come with both that exposure, right? Doing the hard things a little bit at a time, so that we can have those safety signals become more important than the anxiety signals. along with skill teaching and practice. Like, how do we read the bus? I was going to say the bus menu, the bus schedule, and how do we figure that out? So those things are going to go along together. Okay. With that, I am going to transition to Joanna, who is going to talk about medication management.
All right, thank you. So medications, it's important to consider when you're thinking about starting them. They're only a piece of the overall treatment pie. And Dr. Dreyer really eloquently highlighted a lot of these behavioral interventions and other strategies with those tips and tricks that can be considered and should be considered first or in addition to medications. So if symptoms are moderate to severe and they're not improving with those behavioral interventions and other strategies, then may consider the medications, but in addition to all of these other things that Dr. Dreyer talked about. Okay, if you've heard Dr. Tartaglia talk before, she talks about 5 reasons to start medications. And I think these are really good. It's a really good threshold for when to think about when medications should be started. First, if safety is being impacted, number one. An example of this, since we're talking about ADHD today, is if impulsivity leads to some unsafe behaviors like crossing the street without looking, or distractibility, if your child is distracted and they leave the stove on. There's some unsafe behaviors that are occurring because of those ADHD symptoms or anxiety symptoms. Another one, if academics or work is impacted. So, for example, like a short attention span or lack of focus impairs the ability to pay attention in class and learn at their full capacity. Or they're really distracted and they're unable to complete a full task at work. Then those are really impaired and maybe medications can be considered. If family life is being impacted, so distraction or a lot of anxiety or worry before leaving the house can lead to some delays in leaving and cause some tension between family members and some stress. If that's significantly impacted, another reason to consider. And then social life, if there's some social anxiety going on, and that's leading to avoiding social activities that prevents some friendships that could happen. That's another reason to consider medications. And then lastly, self-esteem. So if they're telling you some emotional distress and saying things like, why are things are so hard for me than they are for everybody else, or why can't I do this? Another thing that maybe you can consider medications. So in terms of the timing of starting medications and how symptoms are presenting. So if symptoms present, that is the time to consider those behavioral interventions and other strategies when they present and when they're mild. Think about all those tips and tricks that Dr. Dreyer talked about. And then, as symptoms progress, they could become more moderate to severe and cause some impairment or some problems. And really, that's when medications should be considered. So after those behavioral interventions or other strategies are started, and the symptoms continue to progress and get more moderate to severe, preferably on the moderate side, then think about those medications before you get to this crisis mode, before, your child is an academic failure, or there's significant safety concerns, or there's a hospitalization for a mental health condition. So those are some things you want to start medications prior to that, way before crisis mode. When starting medications, there's always some risks and there's benefits, of course, too. But it's always important to weigh those risks and benefits. And we're going to talk about some of those. So benefits of taking medications is that behaviors and relationships and, stress within the family, that can all improve and improve daily functioning. If you try medications in addition to behavioral interventions, they might become more effective. Those medications really help the behavioral intervention strategies become more effective. They could be more successful academically if they're better able to focus and pay attention in school, and they're not as fidgety or distracted. And they can, lead to that ultimate academic success and reach their full potential there. And also, they can have improvements in social skills and social development when they're feeling more confident. And then also, you can feel more confident knowing that you're pursuing everything that you can do and you're pursuing all the options that could potentially be helpful. Of course, all medications come with a risk of side effects, some more than others. And they also come with the risk that they might not work. We do, tend to go through a list of medications. If they're not effective, we'll go to the next one because people respond to different medications in different ways. They always require some more monitoring. So you might need to have more visits with your doctor. And so that's sometimes a drawback, especially if you live really far away or it's hard to get in to see your doctor. There's always a worry that they might not learn the skills or be able to manage without those medications. And then sometimes, depending on the medication, they require some lab monitoring or monitoring of blood pressure or weight. So that might be required, and that's sometimes a drawback too. So if you don't take the medications, then of course there's not a risk of side effects, there's no cost, and you might be able to find other strategies that can help. But oftentimes taking medications, it can really help with making school and work more manageable. Anxiety can be improved, so they're more able to participate in activities. Not taking the medications can eventually lead to unsafe behaviors, like we talked about before we getting into crisis mode. And behaviors may get worse if you're not taking medications. So those are some drawbacks with not taking them. So a lot of times they're very helpful and very useful in helping. So when thinking about medications to start, it's really important to identify the symptom that is underlying all of the challenging behavior. And sometimes this is really straightforward. Like for ADHD, it looks like inability to focus and distraction and lots of fidgeting and lots of moving around. And sometimes it takes a little investigating in order to determine what that target symptom is. So for example, behavior outbursts or tantrums or low frustration tolerance, maybe all of that underlying is anxiety. And that is actually the target symptom. So it's important to work with your doctor and, explain everything that's going on so that they can help you identify that target symptom so that you can get a medication that targets that target symptom. Because that helps us know what medication to start. Oftentimes, there are several symptoms presenting at the same time, and there's a lot of overlap, and it's hard to tease out what is what. It happens a lot where we have anxiety and ADHD going on at the same time, but we really want to start with one medication at a time. So we'll try and delineate what target symptom is causing the most impairment or the most difficulty, and we'll start there. And then we'll address the other things after. So like I said, it's good to start one medication at a time, and then you can see, is this one medication helpful? Is this one medication causing side effects? Because if you start multiple medications, it's kind of hard to tease out what is helpful and what's causing side effects. We tend to start our medication doses low and titrate up slowly. And we're trying to get to that sweet spot where we're not giving too much of a medication that's causing side effects, but we're giving a dose that is effective. We try not to give more than is necessary because of that risk of side effects, but we do want to get to an efficacy point. So the strategy behind that is to start our dosing low and titrate up slowly to get to that sweet spot, that target dose that is most helpful, but not causing as many side effects. When thinking about different medication options, we always think about the chance of efficacy. Some medications tend to be more effective for symptoms than others, so we might start with that one that tends to work better. But then we're also thinking about risk of side effects. Some medications have a higher risk of side effects or a higher risk of more significant, more severe side effects. So that's always at play when we're thinking about what medications to start. And then some medications interact with the medications that are already on the medication profile. So we might want to avoid those. So thinking about those. And we also want to think about not just medications that are prescribed, but also vitamins and supplements. Sometimes you don't think about those as much, but they certainly come with drug-drug interactions. So making sure that your doctor knows about the vitamins and supplements and over-the-counter medications that your child or adult child is taking as well, so we can assess for that and decrease that risk. And then lastly, medications sometimes target multiple symptoms. So sometimes we can target sleep, we can target ADHD, and we can target anxiety all in one medication. We don't often do that. We usually, start with the one that's most impairing. But sometimes we can do that with one medication targeting multiple symptoms that are going on. And then it's important to ask your doctor questions. So like I said, thinking about options. What are the medications that have the highest chance of efficacy? What are the ones with the highest risk of side effects? And in terms of effectiveness, you want to know what symptoms that medication is going to help and what it's not going to help. And then also when you're going to expect to see this improvement of those symptoms. So some medications work right away and you know that it's working, or you know if it works right when you start it or within a couple of days. And some take several weeks to see an impact. So knowing and having that expectation of when you would expect to start seeing some benefit, it's really important. And then common and serious side effects and what to do if these side effects occur. Some side effects can be mitigated by changing the time of day that you take it or taking it with food or things like that. So you want to know what you can do if those side effects occur. And then some things you can't do anything about it. You just need to let your doctor know, and then maybe that's not the medication for you. And then knowing if there's drug-drug interactions with the current medications or any over-the-counter medications that you might consider trying in the future. So knowing what might interact. And then how to take the medication. Some medications can be crushed and some must be swallowed whole. So knowing how to take it is really important. If it needs to be taken with food or on an empty stomach, does it need to be taken at a certain time of day? Some medications keep you up at night, so you definitely don't want to take them late at night. You want to take them in the morning. And some have the opposite effect. And then how to get in touch with your doctor. This seems pretty straightforward, but it might be hard to get in touch with them if something happens on a weekend or over a holiday. So what to do in those certain situations. All right, now we're going to talk about the medications themselves. So in targeting symptoms of ADHD, hyperactivity, impulsivity, and inattention, we have the stimulants and we have the non-stimulants. And in the stimulants category, we have two different classes. We have the methylphenidate-based and we have the amphetamine-based. So methylphenidate-based, examples of those, Ritalin, Concerta, Focalin, to name a few. Amphetamine-based, Adderall, Vyvanse are some examples of those. And then in the non-stimulant category, the alpha-2s, there's clonidine and guanfacine. Both of those come in immediate and extended release. A lot of the stimulants do as well. They come in all different kinds of formulations. And then we have the norepinephrine reuptake inhibitors. Those are like atomoxetine, other name is Strattera, or viloxazine, other name is Qelbree. That's a new one. It's been around for a little while, but not nearly as long as atomoxetine. So the stimulants, how do they work? So they increase the activity of the neurotransmitters, particularly dopamine and norepinephrine in the brain, and this helps with focus, attention, learning, motivation. These tend to be very effective. They are safe if used under the guidance of a medical doctor with a diagnosis of ADHD. Sometimes they help with fatigue. If there's a lot of fatigue or inactivity, they can help with that. They work really quickly. This is a great benefit of stimulants. You can know right away if the stimulant is working. Like within the first dose or the first couple of doses, you can know if this is a good fit or if it's not a good fit. And you can also take breaks. So you can not take it on a weekend, or you can not take it over a holiday or a vacation. It's not unsafe to take a break. They do tend to cause some appetite suppression. That's probably the most common side effect that we see. They can also increase blood pressure and increase heart rate. Sometimes they cause some irritability. That happens sometimes, not as frequently. And if the dose is too high, we sometimes see like a flat affect, and maybe it's working a little bit too well, but we don't want to disrupt the personality. So we would back up on that dose or try something else. Sometimes we see a rebound effect when the medication is wearing off. So towards the end of the day or the evening, we have this increase in irritability, behavioral outbursts, as a rebound effect of that medication wearing off. And what we sometimes do in that case is add a little bit of immediate release dose in the afternoon to kind of mitigate that rebound effect. But we don't want to give it too late because it can cause some sleep disruptions. And then if your child or your adult child has a history of seizures or a cardiac history, we always want to get it cleared with the neurologist or the cardiologist. Next, we have our alpha-2 agonists. These are clonidine and guanfacine. They decrease norepinephrine within the body, so that flight or fight feeling, that can be softened and mitigated by these alpha-2s. So they sometimes work for, remember I said we could sometimes use medications for multiple symptoms. They work for ADHD, and that's what they're indicated for, but sometimes they help with anxiety too, or behavioral outbursts or aggressive behaviors, and they can be sedating, so we sometimes use them for sleep as well. Other side effects, they can cause some dry mouth or some constipation, and we always tell our patients not to stop these abruptly. That's very important because they lower blood pressure, but if you stop them quickly, then that blood pressure can raise up really quickly. And next we have the norepinephrine reuptake inhibitors, atomoxetine and viloxazine. This is Strattera and Qelbree. So they also increase norepinephrine in the brain and help with that focus and attention. And there's some data to suggest it might also be helpful for anxiety. We don't tend to reach for these first because they take a long time to work, especially atomoxetine or Strattera. Qelbree is thought to work a little bit quicker, and actually there's some data to support that you might see effects within 2 weeks, which is a lot faster than atomoxetine, which may take 4 to 6 weeks to see some improvement. They also need to be swallowed whole, so not a good option for those that need crushed or liquid. And there's a significant drug-drug interaction that is really important to consider with viloxazine that can increase melatonin. So a lot of our patients take melatonin. We recommend it frequently for sleep, but it can raise levels of melatonin, and that can be problematic. So I always advise my patients that are started on viloxazine cannot take melatonin. And because they increase norepinephrine, they can increase blood pressure. Okay, switching gears and talking about anxiety, we have 3 big chunks of different classes of medications. We have the SSRIs, some examples, sertraline, escitalopram, citalopram. We use these really frequently. And then if we experience some side effects, or if a patient experiences some side effects or it's not working, we tend to do another one. We'll try another one within that class because that is our first line option and has the most data to support their use and work the best. But if that is not effective or causes side effects, then we try an SNRI next. So those are like duloxetine, venlafaxine. Those are the two most common ones. And then we have other medications that we might reach to in different circumstances. We'll go through those in a minute. But oftentimes, if they're presenting in different ways or with other symptoms, or we've tried SSRIs or SNRIs in the past, we might reach to these other medication classes. So sertraline, citalopram, these are all examples of SSRIs. They increase serotonin levels in the brain. Like I said, we use them frequently. They're very safe. They're effective. They tend to be very well tolerated and can help with those symptoms or behaviors or irritability, aggressive behaviors that might stem from that anxiety. But patients tend to have fewer worries, perseverations. They can be less tearful, less emotional, have less emotional ability. They can also help with transitions. And then if a patient also has like fixations or OCD type symptoms, these are great for those as well, and first line for that as well. Like I said, they're really well tolerated, but sometimes we can see some GI side effects, or headache is another, maybe a little bit more common. And then sometimes in patients with neurodevelopmental differences, we can have something called activation, what we call activation, which is like irritability, agitation. It might cause some insomnia or hyperactivity. It doesn't happen very often, but it happens more than in the neurotypical population. So that is really why we start lower doses and we titrate up slowly to mitigate the risk of those side effects too. And then thinking about some drug-drug interactions too with those. Fluoxetine and fluvoxamine are the two that come with some drug-drug interactions of the SSRIs. And then for the SNRIs, venlafaxine, duloxetine are the two most common. They increase serotonin and norepinephrine in the brain. And because they work on that norepinephrine, they're also sometimes helpful for ADHD. And venlafaxine in particular has some literature or some studies that support its use in ADHD as well. They can, because that impact on norepinephrine, it can increase blood pressure. And then there's some drug-drug interactions with duloxetine and a slight increased risk of seizure with venlafaxine, so avoiding that. And then here's the others that I talked about. So propranolol, I really like. It's really helpful especially for situational anxiety, or if there's that like physical symptoms of anxiety, like sweaty palms or fast heart rate, it's helpful for that. Some of our patients have a tremor, so it's helpful for that as well. It is a blood pressure medication by trade, so it can decrease heart rate and blood pressure. And so other medications that can also decrease heart rate and blood pressure, like the alpha-2 agonists, being careful with those. And then in patients that are taking a beta-2 agonist like albuterol, it mitigates that effect, so limited use in that population. Hydroxyzine is sort of the same as propranolol in that it's sometimes helpful for that situational anxiety. It does tend to be really sedating, so sometimes we use it for sleep, or in a lower dose during the day for anxiety and a higher dose at night for sleep. And really the side effects are that sleepiness and can cause some constipation as well. And then those with neurodevelopmental differences too tend to have a slightly higher risk of a paradoxical reaction, which is like an opposite of reaction of what you would expect. So like agitation and excitation instead of like sedation. And then I talked about the alpha-2 agonists for ADHD, but I'm talking about them again here. They can also help anxiety type of symptoms. So we sometimes, try and target both with the alpha-2, Although we usually for ADHD, and if that's our main target symptom, we'll start with a stimulant because they tend to work better and they have a higher efficacy. Bupropion also has some data for ADHD, so can be helpful for anxiety and ADHD. It does have a risk of drug-drug interactions, so it's not a go-to. And then buspirone doesn't tend to work quite as well for anxiety, but we might consider it. There's some data that it may be helpful for irritability and aggression too, so maybe a patient that presents with both of those. And then mirtazapine is really helpful for a very particular subset of patients where they have a low appetite because it improves appetite and can cause some weight gain. Definitely that's not for everybody, but those with a low weight or low appetite, it can be helpful for that. It also tends to be sedating. So if they have trouble sleeping, it can be given once a day at night. So, and then helpful for anxiety and then irritability and aggression. There's some data for that. So sometimes we'll reach for that if there's all of these other things going on to cover all of those things. And then lastly, I just wanted to talk quickly about pharmacogenomic testing. So this is a genetic test. It looks at genes that code for the enzymes that metabolize or break down medications. So medications, most of them, for the most part, they go from the active form and they get broken down or metabolized to an inactive or a less active form. So poor metabolizers they won't break that down as well or as quickly. And so they'll have more active form and then they have a higher risk of side effects. Whereas rapid metabolizers, they'll break down that active form really quickly and then they'll have the potential for less efficacy, right? But this pharmacogenomic testing does have implications for ADHD and anxiety meds, as well as other psychotropic medications. So we tend to try it or obtain it or recommend obtaining it in those that have tried several medications that don't tend to be helpful, or they've had a lot of medications that maybe have caused side effects, to try and see if we can get some more information and see if there's some differences in the way that they metabolize or break down those medications. And then hopefully that helps us guide what our next medication choice is that wouldn't be impacted by those variances in the genes that break down medications. And then it's great that testing can be done with a cheek swab. It doesn't necessarily need to be a blood test. So those that have a hard time with needles, this is still a consideration. And then I'm going to hand it back to Dr. Dreyer to just summarize and finalize the presentation, and then we can open the floor for questions.
Yeah, I know there are a lot of questions. I'll keep this very short and sweet. Anxiety and ADHD impact teens and young adults with XY chromosome variations at higher rates. The presentation, like we've talked about, is more complex, and there are unique things to consider when we're thinking about diagnosis and treatment planning. And luckily, there are many available treatment options, including behavioral mental health interventions, medication interventions, and at-home strategies and tips and tricks.